It is my pleasure to introduce Dr. Kristen Riley. Dr. Riley is an associate professor in the Graduate School of Applied and Professional Psychology and a licensed clinical health psychologist. Dr. Riley received her PhD in clinical psychology with a health psychology concentration from the University of Connecticut. Her research and clinical work focuses on health equity and the integration of behavioral medicine into medical settings, with a particular expertise in psycho-oncology, behavioral sleep medicine, smoking cessation in underserved groups. She's the director of the Health Psychology Clinic at Rutgers gsapp, offering much needed supports to people with cancer, people with sleep disorders, and people in the perinatal period, and notably offers these services in both English and Spanish. She previously served as the chair of the Health Policy Council for the Society of Health Psychology. And when we conceptualized this series of 5 talks together with the chancellor, we just were so glad to have an expert in behavioral medicine and sleep here at Rutgers, because it was a common thread across each of the conditions that we're talking about here today, which is additional sleep and health related problems. And we're just grateful for Dr. Riley and her expertise in taking the time to be here.
Wow, thank you so much for that lovely introduction. I'll try to live up to it. Hi, everyone. I'm Dr. Kristen Riley here. You heard all about me already, so no need to go through that again. Today, I'm here to talk with you a bit about evidence-based skills and strategies to address sleep problems. So we'll be going through some specific skills, some information about behavioral sleep patterns and behavioral sleep treatment that you can implement or share. Some specific strategies such as progressive muscle relaxation and worry time, a ton of resources, a little primer on motivational interviewing, and as always, I am here to provide resources before, during, and after the talk. So first, let's get started and centered for our learning today. And a great way to do so is with a relaxation strategy. This is not the end all be all of sleep medicine, as you will hear. Actually, our behavioral sleep treatment usually hinges more upon our biobehavioral sleep patterns, and sleep squishing and sleep scheduling. Though tools like progressive muscle relaxation can really help and support. Over the years, a lot of my patients, who range from teenagers to adults, love progressive muscle relaxation as a primary strategy for helping to fall asleep and stay asleep, as well as induce the relaxation response throughout the day to create more biophysiological signals that sleep is safe. And my 7-year-old loves this too. Last night she was like, I'm having a hard time going to sleep. I'm tired, but I can't sleep. So we did muscle squeeze and releases. So I hope you'll join me today. That we'll start out strong with our first skill. So, if you'd like to close your eyes or focus on a point in the room, and first, just take a few deep breaths, knowing that there's nothing else you have to do, nowhere else you have to go, then be right here breathing. Ah. And whenever you're ready, we're going to start tensing and releasing the muscles in our body. This can be done all together, whole body tense and release, or it can be done in muscle groups throughout the body. The only contraindication to this practice or something to look out for is if you start feeling pain anywhere. Tightness is okay, pain is not. So if you start feeling pain someplace, just back off, don't tense it as much. Or if there's an area of your body that you can't tense for some reason, just focus your mind on that. So we'll start out by focusing on the muscles of our face, neck, and shoulders. We'll squeeze them all together for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and relax. Noticing any difference from before and after. Now we'll move our attention to our arms. Just notice your arms all the way down to your fingertips and make fists and squeeze your arms up for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and release. Just noticing any difference from before and after. Now we'll turn our attention to our abs and back, trying to tense those muscles in your core as much as you can for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and relax, letting it all go. And then we'll turn our attention to our legs from our seat all the way down to our toes, maybe pointing your toes and tensing your muscles for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and relax. Just noticing the difference. Take a few more deep breaths, thanking yourself for making time for this practice today and practicing this. And whenever you're ready, you can stretch, open your eyes, start coming back into our shared virtual space. So thank you. Many of you likely already know this, but if you don't, that was progressive muscle relaxation. People with sleep issues love it, kiddos love it. There are a lot of YouTube videos out there, so you can explore and pick your favorites. There are very few contraindications, and it has been shown in biophysiological research as well as self-report measures to induce the relaxation response, which is really important for sleep and general well-being. Audio only is recommended rather than watching the screen. We'll talk about that more in a minute. And then for kids, you can just say something let's squeeze and release our muscles a couple times. And count to 10 or count down from 10 or count to 5. Um, and see if it helps. There's also the Headspace app. There's a paid version, but there's a lot of free stuff on the unpaid version too that include things like monster meditations, things like smelling the flower, blowing out the candle, that can be really supportive of inducing that relaxation before bed or to get back to sleep. So welcome, with immense gratitude for the Chancellor for this wellness series and the Center for Youth Social Emotional Wellness for this talk today. Our agenda, and hopefully it won't put you to sleep. It's pretty icky and rainy out here and outside, but we're going to talk about sleep. Hopefully, you'll stay awake though. We're hoping to, and rather than 10 to noon, this is noon to 1. So apologies for that. But we're going to first talk about introduction to sleep, circadian rhythm, sleep disorders, and behavioral sleep treatment. Then we're going to be talking about specific skills for youth, including for practitioners and parents, about sleep restriction and worry time, motivational interviewing skills for negotiating with kids and teens, especially. And then a ton of resources. You'll get your screenshot ready towards the end with a lot of my favorite resources, websites, as well as providers. But first, I would love for this talk to be as maximally effective and applicable to you as possible. So I would love to know in the chat what you identify as, whether you're here as a parent, practitioner, community member, and then what you might hope to learn today so that I can tailor this talk accordingly. Parent of a tween here. Great. A practitioner, student clinician, strategies with kiddo clients, parent and counselor, parent of 16-year-old, parent and practitioner. practitioner, parent of five, MSW, LCSW, special ed high school teacher. Okay. Student and sleep strategies, resources for adult clients, MSW, parents, sleep struggler myself, and let's connect offline about that. I got you. And practitioner, Rutgers employee, practitioner. Beautiful. Oh, this is great. Hoping to help with sleep strategies for busy parents with young children. That's me too. So I got you. Um, Students, parent of a teenager, doctoral candidate working with kiddos, parent, special considerations for clients with special needs like autism. We have treated a few of those clients, and I do have some resources for you. How to help people stay asleep, someone with sleep difficulties. Okay, great. Help sleep with young kids and also adults. So, we will definitely make time for more specific questions at the end, but I will try to address as many of these topics as possible that I see coming in. So first, I'd like to talk to the person who created the phrase sleeping like a baby, because it's pretty rarely like this and more like this. If I don't sleep, nobody sleeps. Okay. And sleep issues are quite common among youth and adults in our country. And all of this map is from 2014, but all of our recent data, especially post-pandemic, is showing that these sleep issues are getting even worse. So you can see that a lot of folks reports sleep difficulties. And in our area of the United States, here in New Jersey, you can see that we range from about 25% to 50% of adults and children reporting sleep difficulties. And so sleep issues are quite common. In addition, about 50 to 70 million US adults have a diagnosable sleep disorder specifically. So here we're talking about sleep difficulties, sleep issues in general. And here we're talking about like one level higher, diagnosable sleep disorders. We'll talk about the difference and how to treat them differentially. Um, Almost 40% of folks reported unintentionally falling asleep during the day. Insomnia is the most common sleep disorder, with around reported by 30% of adults, and chronic insomnia among about 10% of adults. 25 million US adults have obstructive sleep apnea, or difficulty breathing while sleeping, that you don't even realize it wakes you up, but it wakes you up many times throughout the night. You usually don't remember a wake up unless it's longer than 2 minutes or so, which is super interesting. So we always screen for obstructive sleep apnea in adults before treating insomnia. And for people with likely obstructive sleep apnea on the Stop Bang questionnaire, we send them over for a sleep study or to a sleep clinic. Most adults need about 7 hours of sleep. We'll go through the recommendations for children as well. Um, okay. We all know that sleep is quite important. Um, Sleep is related to poor mental and physical health, including all of these things listed over here, including memory issues, mood changes, weakened immunity, risk for diabetes, for adults, low sex drive, trouble with thinking and concentration, the risk of accidents during daylight savings time switches every year. That Monday after daylight savings times, there's a huge spike in car accidents. So be really careful on the road this week and next week as we all adjust to the time change. High blood pressure, weight gain, risk of heart disease, and poor balance. We know as psychologists, it relates to the risk of developing and poorer recovery from psychological disorders, including depression and anxiety. Now, parents, this is a scary list. So don't worry, we've got you. Some sleep difficulties are relatively common in kids, and most kids don't grow up to develop psychological disorder, diabetes, chronic health conditions. Okay. So just want to put that into context because whenever we're talking to parents, your heart is in the right place and you can't help but worry. Just outlining some of the science behind why sleep is so important. It literally impacts everything, right? So what do we do about it? Well, first, whenever I see a parent or a kiddo or an adult um, out in the world or in a clinic reporting sleep difficulties, we want to make sure they have first adequate opportunity for sleep. So, as a clinician and as a parent, we want to make sure that they're getting adequate opportunity for sleep. This is more common in things like teenagers when they're like up late playing video games or talking to friends or on screens, or adults when we're doom scrolling, things like that, right? That could happen in kids too. A lot of us lead very full lives. Kids need to be up early for daycare, need to be up late to see grandparents or special events. We want to make sure we are first ensuring an adequate opportunity for sleep and making space for the recommended number of hours per sleep. So for infants, so just want to also emphasize that there is a wide range of normal here. If you have a question like, "Ooh, my kiddo's very different than this range that Kristen's talking about today," talk to your pediatrician or your primary care doctor. But yeah, recommended hours of sleep per night for an infant are about 12 to 16 hours, including naps, including daytime naps. 11 to 14 hours for toddlers, 10 to 13 hours for preschoolers, 9 to 12 hours for school-age kiddos, and then 8 to 10 hours for teens. Note that this number is actually pretty high, right? 8 to 10 hours for teens. So, because they do need more sleep than adults, we sometimes don't prioritize making extra time for sleep. Increasingly, school districts are recognizing that it is quite important to make school start times late enough so that kiddos can sleep enough, right? Because it's hard to do your homework, dinner, sports, whatever you have after school, and get in bed on time enough to sleep with like a 7 a.m. school start time. I was thankful to be one of the folks working for legislation in this area that New Jersey has been working towards like passing and implementing. And as adults, we need 7 or more hours of sleep. There's also some range here. Let's talk about sleep disorders first, too. So first, we make sure that there's an adequate opportunity for sleep. Second, before we intervene on any sleep issues, we want to make sure that there's no sleep disorders that might require more specialized treatment or pharmacological treatment. These are much more rare, but we always check in before treatment. So first, especially for adults, you always screen for behavior or breathing related sleep disorders or sleep apnea. There's something called the Stop Bang questionnaire. That is a quick 8-item questionnaire that talks about, let's see if I can remember, snoring, tiredness, obstructive breathing, age, neck circumference, gender. Um, so it's a quick screener, and if someone scores 3 or higher on that stop bang questionnaire, then we refer them to a primary care doctor or a sleep clinic to get a sleep study. Because if someone is biologically waking up at night because they stop breathing 5 to 40 times per hour during the night, then we want to make sure that they get that fixed, usually with CPAP machine, um, which is a mask that you wear that pressurizes air into your lungs, keeping your airway open. So this is like your airway. And when you have partial sleep apnea, everybody's uh, tube that they breathe through, that's how I describe it to patients, collapses a little bit at night. For people with sleep apnea, it collapses too much. When it collapses a little bit, you hear vibration or snoring. And when it collapses all the way, people stop breathing for, again, anywhere from 5 to 40 times per hour overnight. Most of the time, they don't realize it. It makes you very sleepy during the day, and it confers risk for cardiac events, high risk for cardiac events. So, in order to keep people alive, we really want to screen for sleep apnea and refer to primary care doctors. This is for adults. It's much less common in kiddos, but if you're noticing a kiddo that snores excessively or that stops breathing in their sleep, gasps a lot during their sleep, it's very much worth talking to your pediatrician about it. In addition, we see that there are things like restless leg syndrome, where you feel like you have creepy crawlies or bugs on your leg and you have to move your legs before falling asleep. And usually that is a referral to a sleep clinic for adults. They usually prescribe a low dose muscle relaxant. For kiddos, they'll do a panel of blood work and see if there's any over the counter or prescription medications that can be used to sort of soothe that for sleep. There's also things like narcolepsy, and hypersomnolence disorder, nightmare disorder that can be diagnosed by a sleep clinic or with a sleep study. Um, so yes, step one, making sure they have enough time for sleep. Step two, ruling out more of the extreme sleep disorders that will require an expert. And if this is you, if you're like, ooh, I might need a referral to a sleep clinic, don't worry, I have sleep clinics listed at the end. There are wonderful sleep clinics here at Rutgers and Robert Wood Johnson for pediatric and adult sleep disorders. And I work very closely with the adult sleep disorders clinic here. Okay. So once you've ruled out sleep apnea for for adults mostly, but also kiddos and other sleep disorders like restless leg syndrome, then we move on to thinking about, okay, how do we fix these problematic sleep patterns? Insomnia, which is difficulty falling asleep, staying asleep, or waking up too early more than 3 nights a week for more than 3 months. But even if it's like close to that, like subclinical, or they're having sleep difficulties, a lot of these behavioral sleep principles will help get it under control. Um, so this is the model of insomnia that's really important. Jessica Hamilton at the School of Arts and Sciences, an assistant professor, and also a psychologist, does a lot of research in this area. And she shows that if we understand these behavioral sleep issues and sleep patterns, that we can do a lot of self-management of subclinical insomnia, sleep issues, and insomnia, which is why I'm going through this today. This is not just for fun. This is if you know these principles, you can fix a lot of sleep issues on your own. But if you can't, we're here. Okay. So, how does insomnia develop? Well, there's usually some predisposing factors like biologic traits. Some people are just more biologically predisposed to insomnia disorders. Psychological traits, like the presence of another mental health disorder. Um, Social factors, other biological factors like the presence of disability or disorder that might predispose you to insomnia that like increases the load. Then there's usually some precipitating factor that produces the onset of insomnia or insomnia symptoms, including things like medical illness, psychiatric illness like anxiety and depression that either keeps you up late at night or keeps you sleeping too much, or stressful life events. I'm sure you can all relate to this, right? So, like, we've all had times when we've been sick, we're napping too much, we're sleeping in, and then we can't fall asleep at night. We'll talk about why on the next page. Um, But this causes disruptions in sleep that can then persist due to perpetuating factors like excessive time in bed that causes conditioned arousal. We'll talk about what that is and how to decrease it. Excess napping, which decreases your sleep drive and so causes you to wake up more at night. And then conditioning, so associating your bed with tossing and turning. So, let's talk a little bit about our biological circadian rhythms. So, for most folks, um, there are two sleep drives. One is the circadian drive for arousal, process C. That's this one, this green line, and homeostatic sleep drive, which is process S. And this builds your desire for sleep over the day. Okay, so the homeostatic sleep drive is pretty straightforward, right? You want to sleep more and more and more throughout the day. And then once you hit nighttime, then you fall asleep, and your sleep drive decreases. Your drive, your biological desire to fall asleep decreases. Then we have this circadian drive for arousal. It's anchored on your wake time. So this is why we want to have a consistent wake time during the week and on weekends. Okay, so this is a primary thing for teens. We want to make sure they're getting enough sleep every night, ideally, so that their wake time can be the same at night and on the weekends. Same with kids, same with adults. You want to make sure you're waking up at the same time every day. Otherwise, it's like jet lag, right? It throws off this process C, and your body doesn't know when to keep you awake, when to let you fall asleep. This process is all over the place. So you're going to feel drowsy and out of it. You're not going to be able to fall asleep at night. You're going to be waking up more in the middle of the night because you don't have enough sleep drive built up. Okay, you want to build up this sleep drive throughout the day a lot so that you can make it through the night to sleep. This is also why you don't want to spend too much time in bed because if you spend too much time in bed, you're not going to be able to make it to your wake time. So say that your anchor for your circadian clock is 7 a.m. Okay, and on average, you're an adult, you need about 7 hours of sleep. You want to go to sleep at around midnight and not depending on your sleep needs, which you'll figure out over time, but you're not going to want to go to sleep at 10 p.m. because your body doesn't have enough sleep drive to make you sleep for 9 hours when your body wants to sleep for 7 hours. And you have that anchored wake time at 7 a.m. Okay? So this is a mistake is going to sleep too early. Um, which seems counterintuitive, but you don't want to spend too much time in bed. Your body won't be able to make it the whole time to your wake time unless you have adequate sleep drive built up over the day, and your body can make it to your wake time. Okay, so consistent wake time every day. For people without sleep difficulties, wake up within the same hour every day. For people with sleep difficulties, wake up within the same 30 to 40 minutes every single day, including the weekends. Otherwise, I've met people who like sleep until noon on the weekends and try to wake up at 6 a.m. It's like traveling to Europe or California and for the weekend and coming back again. Your body doesn't know what time it is. So it's a consistent wake time, quite important. Not going to sleep too early, also quite important. So this circadian drive is pretty cool. As you get more tired over the course of the day with your homeostatic sleep drive, there's this sleep bump or this circadian bump for arousal to stay awake that happens in the afternoon so that you don't fall asleep. And it peaks around 6 p.m. So if you've ever tried to nap at like 6 p.m. and you're like, oh, why can't I sleep? I'm so tired. It's because of your circadian drive for arousal. As you get more and more tired throughout the day, it doesn't want you falling asleep too early because it knows you won't be able to make it until morning time. Um, And so these are regulated by neural networks and areas of your brain and neurotransmitters. Um, we also pay attention. So, a few takeaways from this chart alone. Consistent wake time. Don't go to sleep too early. If you nap, if you absolutely need to, we recommend no napping for adults who have sleep issues because it lowers your sleep drive and then you'll be able to make it through the whole night. But if you absolutely need a nap or you have a kiddo that's still napping, early afternoon, and then sometimes capping the nap or making it a little bit shorter. You'll have to play around with this a little bit. So those are some takeaways. Wake at the same time every day. Don't go to sleep too early. Short naps in the early afternoon for teens, adults, and older kiddos. Um, if needed, if absolutely needed. This also, these biophysiological processes and neurotransmitters matter for screen time. So the next lesson is going to be don't look at your screens 90 minutes before bed. Yes, it impacts your sleep. So long ago, before we had lights and electricity, our brains were trained to see light outside, see the sun, and produce signals in our brain that say, stay awake, stay awake. And when it sees the dark, it produces signals in your brain that say, go to sleep, go to sleep. It starts the relaxation response, it releases endogenous melatonin, and works on those related receptors and it puts you to sleep. Blue light is particularly bad for keeping you awake and sending those wake up signals. So no screens 90 minutes before bed. Okay. Before we get into um Pavlov, which does have something to do with sleep, and then a few sleep skills, because I know that's what you're here for. I'll pause for any questions and I'll check the chat here too. Mhm. Samantha is asking about CPAP adherence. Um, yes, if we have time at the end, I will go through CPAP adherence tips and tricks. I ran a CPAP adherence group at the Miami VA, so I got a lot of tips and tricks from those veterans. Oh no, Rhonda, you got 3.5 hours of sleep last night. Please take a nap. How long should a nap last? Great question, Tamara. Um, It depends. So there's a lot of research that shows that just a tw 10 to 20-minute nap for adults is restores a lot of like cognitive processes and doesn't deplete sleep drive too much. So everybody's a little bit different here, and I would do trial and error. So a lot of this is trial and error, which is a little frustrating because you have to know yourself, your kid, your own biological predispositions. And it does take about 2 weeks to set like a new wake time to get used to a new sleep pattern. So you'll have to do a little bit of testing here, but Tamara, a nap of like 10 to 20 minutes should be all that you need if you absolutely have to. How do we as adults help our sleep patterns when we work? Oh, shift. Yeah. There's actually a sleep disorder called shift sleep wake disorder, and it's for shift workers. It's incredibly difficult. And we do the best we can. Um, I would recommend like trying to keep the same sleep schedule whenever possible, or when you're working nights, and drive home in the morning, like prevent your and this is related to any clinician who might work with like a nurse who does night shifts, a shift worker who might switch shifts. So first of all, working a consistent shift would be the ideal answer, not switching shifts because it is quite impactful negatively on your health. But second, if you have to work a night shift, using like blue blocker glasses on your way home, blackout curtains, or putting like blankets over your windows, um, and creating a really cool, calm environment for sleep, white noise, things like that, can be really supportive of sleeping during daytime hours. And then actually like extra blue light before going to work at night. So using those neurotransmitter day and night signals to our advantage can be really helpful. What about for ADHD and ASD? When people get burned out from school, are there ways to recover without napping? Really great question, Shiwei, and I hope you're pronouncing your name correctly. Um, yeah, that's probably a good question for Dr. Langberg too. But in my experience, yeah, short naps can be really supportive for people with ASD and ADHD. There are some biomarkers that are very different in people with ASD that do create more sleep difficulties. So it's just always something that you're battling with, and every person is different. But I'm sure Dr. Langberg can also help with additional tips and tricks for recovering from ADHD related burnout. Um, do the 7 hours need to be consecutive? Great question, Suzanne. Ideally consecutive, right? Because it'll help your body learn how to sleep through the night. But the director of my sleep clinic that I worked with for at the Miami VA, who'd been doing this for many years, said that what really mattered is like the total amount of sleep in 24 hours. Although personally, I'm very pro getting all your sleep at once. Are the sleep disorders hereditary? In part, yes. Yeah. Lisa said instead of CPAP, I have a mouth device for my doctor. Is this as effective? Yes, it is for low AHI or more mild sleep apnea. It can be equally as effective. Um, for adults without sleep issues, are naps still not recommended? No, if you don't have sleep issues, go ahead and nap. It could be really helpful for like cognitive recharging and recovery. Teens who get home from school till later afternoon should not nap then, right? I guess it depends, Suzanne. You want them to get enough sleep in general and not sleep in too much on the weekends. So if they don't have adequate opportunity for sleep during the day, or during the night, and they're sleeping in a bunch on weekends, that's probably more harmful and more likely to cause insomnia than a later afternoon nap. This might have to be trial and error, though. And if they nap right away after school, that for a short time, that might be fine. Wow, these are really cool questions. And I wanna melatonin. Okay, okay, hold your question. I have a melatonin slide. Blackout curtains have been so helpful, yes. And menopause, thank you so much for asking that, Rhonda. Okay. Um, so I'm not a pharmacologist, so I can't answer questions about medications, but I can talk about um, melatonin. And yes, thank you for bringing up perimenopause and menopause. So for adults, yes, perimenopause and menopause mess with your hormones, your whole endocrine system. It throws off your sleep. It increases the likelihood of insomnia. Hormone replacement therapy is very effective and safe for reducing insomnia and perimenopause and menopause related symptoms for mental and physical health sequelae during that period of time in your life. Historically, there had been some fear about the increased risk of breast cancer among people with who use hormone replacement therapy that have been a barrier to care. However, more recently, they've shown that that risk is very, very small, if non-existent. If not non-existent. So if you have any concerns, talk to your OBGYN. Um, and it actually prevents against other things like ovarian cancer. And so, yes, speak to your OBGYN definitely about hormone replacement therapy if you're having insomnia related issues in perimenopause or menopause. I'm definitely going to get to the rest of these questions, so hang tight. But I saw a couple that I'm going to answer in these slides. So, what does Pavlov have to do with anything? So, a lot of you clinicians already know this. A lot of you parents probably have run into this at some point in your life, that we have something called classical conditioning that happens. There are just these automatic connections in our brain that happen when two things take place at the same time. For insomnia, it's called conditioned arousal. It happens when you toss and turn in bed, you're awake a lot in bed, you're worried a lot in bed, and you start to associate bed with tossing and turning, bed with stress, and we call this conditioned insomnia. How do we fix this? You only use your bed for sleep. So you start to associate bed with sleep, not bed with work, not bed with playtime, not bed with screen time. Yes, like for people with sleep disorders, we recommend even reading somewhere else. Bed is only for sleep. Okay? Um, a calming, predictable bedtime routine can create classical conditioning neural networks that say it's time for sleep. For kiddos, this should be a short half-hour routine without screens. It can be as simple as brush teeth, hugs, good night. There are a lot of cool checklists that are available. These can be also really useful in anchoring for people with um, neurodevelopmental disabilities and disorders too, like a visual checklist of what you're doing every night, depending on ability level. Um, if you're awake for more than 20 minutes trying to get to sleep or in the middle of the night and you have insomnia, get out of bed. Get out of bed, do something gentle, calming, in dim light, like a puzzle, reading a story, listening to something calming, playing an instrument as long as it's calming, and not like heavy metal. And then once you're tired, lay back down again. Okay, this is especially important for people with conditioned arousal. This isn't necessarily important if you don't have sleep difficulties. This is for people with conditioned arousal or with conditioned insomnia. Don't get in bed too early because that'll make you toss and turn. And don't stay in bed when you wake up. So when you wake up first thing in the morning, you don't want to lay there, scroll on your phone. You don't want to lay and try to fall back asleep. Once you realize you're up, get up out of bed. Stand up, expose yourself to bright light that tells your brain to wake up. It reinforces that circadian rhythm anchor for your day and helps you wake up for the day. There is a an intervention that is extremely effective for insomnia, like 93% success rate, you guys. It's amazing, called cognitive behavioral therapy for insomnia, or CBTI. You can find a lot of information about CBTI principles and practices and some apps. The VA actually has a really good app um, for CBTI that targets this. The main active ingredient is sleep scheduling and sleep restriction. So, what we do is we ask people to fill out a sleep diary every day for about a week. We note the amount of time that they're actually sleeping, and we ask them to only sleep that amount of time. So, we squish all their sleep together. So, if someone's only sleeping 6 hours a night, then we ask them to just sleep 6 hours a night, like from midnight to 6 a.m. And not get in bed unless they're tired. If they're in bed and tossing and turning, to get up and do something relaxing and to wake up first thing in the morning, no matter what. This addresses stimulus control, sleep restriction. We include relaxation strategies and worry time, which is the next skill we'll talk about. Gentle cognitive restructuring around worries about sleep. And sleep identity, like identifying yourself as an insomniac, can be really protective, and you can challenge that a little bit sometimes too. And circadian rhythm entrainment, or making that circadian rhythm really strong by waking up at the same time every day. It's a magical intervention with a magical Excel spreadsheet, and it works pretty quickly. It's usually just like 2 hour long sessions and then an additional 4 half-hour sessions, and that's it. We squish people's sleep for 2 weeks to teach their body how to sleep through the night. And then we slowly expand that window until they're sleeping pretty well and feeling pretty rested during the day. What is normal when you're dealing with sleep issues? Nighttime fears and nightmares are really normal in kiddos. Having a script to use, like, I'm here, you're safe, go back to sleep, can be really calming for you. It's hard as a parent. Um, it's good to hear that common script from a parent and a safe voice, even if it's still most sleep. Sleepwalking and sleep terrors are similar. If it's excessive or lasts longer than 6 months, you can talk to your primary care doctor or a sleep doctor about it. And difficulty falling asleep or staying asleep. Think Pavlov, think conditioned conditioned arousal and countering it with conditioned relaxation. Relaxation strategies at night, very consistent calm routines, sleep squishing, going to sleep a little bit later and waking up at the same time every day. When to see a specialist? If it's really impacting the kiddo or person's quality of life, if they have an indication for another sleep disorder, um, or significant behavioral problems. So again, consistent wake time, consistent bedtime routine, sleep environment is dark and quiet and cool, ideally. Um, What we will talk about next is melatonin and then the skill of worry time for kids. So, melatonin is interesting for both adults and kiddos. It seems to kind of work for some adults and kind of work for some kiddos and not work so well for others. This is in part a biophysiological reaction, right? We make like endogenous melatonin in our brain when we go to sleep, so it makes sense to supplement it. However, some studies have shown that it's primarily a placebo effect. You know, you think you're taking something, so you sleep better. Um, and it potentially takes away from our internal locus of control around sleep, or our ability to conceptualize that we have control over our sleep, right? And so when people do CBTI, we ask them to not really take anything. But if they're like, you can pry my melatonin out of my cold dead hands, we're like, okay, take it. Like it works for some people and not for others. Melatonin overdose and toxicity is increasingly common in kiddos. And something to really watch out for, store it in a safe place. Always talk to your pediatrician before giving a supplement like melatonin or other over-the-counter um, sleep supplements for kiddos, especially. There are ones that I've looked up that have like GABA receptor agonists that impact a lot of different neurotransmitters in your brain. And we don't know what the short and long term side effects are for these things. They are not regulated by the FDA, these supplements, and they come in a lot of different doses. Your pediatrician or PCP can see about the indication or contraindication for you and your kiddo. So talk to your doctor. Be really careful with melatonin. You probably don't need it. It has been shown to be, there have been some trials in kiddos with ADHD and ASD for whom it's been shown to be a little bit more effective for helping with sleep. So if that is you, or if you treat kiddos in that category, just encourage kiddos and adults to speak with their pediatrician and PCP about dosing recommendations, as well as any contraindications. I'll teach another sleep skill for kiddos. So in addition to this advice, progressive muscle relaxation, we also have something called worry time. So we recommend this for our adults as well. A lot of times we are so busy as human beings in today's society throughout the day. I don't know about anybody else, but you're running around all day, and the only time you have to worry or plan your next day is when your head hits the pillow at night. It's similar with kiddos, and it makes sense to make time at another time in the day when you're not in bed to worry because your brain will know, okay, I don't need to worry about it now at bedtime. I can worry about it at worry time tomorrow. And it'll allow you to plan, think things out. So for adults, we usually recommend that people do this at lunchtime, like in their lunch break or the early afternoon, and scheduling it in for a half hour every day. Similarly to kiddos, this is a worry time sheet that's available through the American Psychological Association website. Um, and it's a little worksheet that you can fill out with a kiddo about worry time. This is a time to think, write down, journal, or draw about things that you're worried about. And it can be really supportive for reducing that nighttime worrying because your brain has another time to do that worrying. And I want to leave time for answering questions. So just want to briefly point out that any sort of behavior change is really hard, and we lean into our motivational interviewing skills. A lot of you clinicians will know this, but recommend a primer on motivational interviewing available through the gsapp CE site, or as well as my introduction to cognitive behavioral therapy for insomnia talk. There's also plenty of other really cool trainings in CBTI, including at Penn Medicine. And there's a lot of great motivational interviewing trainings through Mint, the organization that does training in motivational interviewing. Anytime we ask someone to make a behavioral change, you express a lot of empathy because it's hard. Roll with resistance, expect that they're going to move between stages of change. Listen for change talk and emphasize it, and then try to couch it in things that are important to them. So these are the stages of change, including like you don't want to make a change, where you gently raise the possibility, what if you made a change? Well, what if you did this, right? Where you're thinking about making a change, where you talk about the pros and cons to changing, and then the planning stages where you get into nitty-gritty details. Um, Expecting some resistance can be really helpful. Behavior change is hard, sleep changes are hard. So for you, your kiddos, your adults, setting this up as an expectation and knowing it for yourself so that you have some patience with the trial and error and the natural processes of things and seeking out support. We also use our ORs in motivational interviewing, asking open-ended questions and providing reflective listening. This might be something like, um, yeah, it is really hard to, go to sleep right now when you don't want to. I hear you. And we're still going to go to sleep, like setting some boundaries. Um, just a note to be really careful about misinformation. There's a lot of people who want to charge $1 million for, not a million, but a lot of money as a sleep consultant. One of my former students did her dissertation on sleep consultants, and a lot of them have very little information or training. So just make sure that whatever resources you seek out are evidence-based. So this is a time when you can screenshot this big list of resources, including the National Sleep Foundation that has a lot of information, Rutgers Pediatric Behavioral Sleep Specialists that are here to help, as well as the Rutgers Sleep Clinic that I work really closely with. I run the health psychology clinic. And this is how you can reach out to us via this email address. Dr. Craig Canapari is a behavioral sleep specialist, pediatric behavioral sleep specialist, who has a lot of great resources on his website that are evidence-based. And then here are a few folks who are experts in this area, as well as some additional resources for youth, anxiety, and depression. So I'll scroll through our questions now. Feel free to drop more questions in the chat. I know we only have an extra 5 minutes or so, but I want to leave this resource screen up. I'll move to my email address at the end. It's one of my favorite things in the world to talk about sleep, answer questions about sleep, provide resources, or connect you to services. So also please reach out to me if I can help. Okay, so back to these awesome questions. Parents who work the night shift but need to be active throughout the day with their kids, getting just consistent chunks of sleep that add up to enough over 24 hours can be really helpful and supportive. It takes a lot of creativity, though, Destiny, for those types of parents. It's just really tough. Um, okay, do I take the hit and keep the wake up time? Valerie, how do you keep this sort of schedule with weekend activities? Good question, Valerie. So, when you're doing like CBTI, you do the sleep squishing for 2 weeks and then expand the amount of sleep people get. So it's tough for 2 weeks and then it's better. You should, in the long run, try to wake up within the same about 45 minutes every day. Yeah. Um, is melatonin okay for a child with ADHD and sleep problems? I hope I answered that. There's some evidence to support that's helpful. Talk to pediatrician or prescriber. Um, get teens awake at early times over the weekend since they have to get up at 6 a.m. for school. This is really, really tough because they probably have some sleep debt from over the week, but we don't want them to wake up too late on the weekends or it throws off their circadian rhythm. So allowing them to sleep until like 7 is great. It sucks that they have to wake up at 6 a.m. for school. Making sure that they get in bed by like 10 p.m. or 9 p.m. at night can be really supportive for waking up at a reasonable time on the weekends. There won't be as much sleep debt if they're getting enough sleep during the week. I know how challenging it can be. You can play music, plan things in the morning that are incentivizing, like making their favorite breakfast. My grandmother threw water on me to wake me up. I don't know if I necessarily recommend that, but was effective for me. It's just really tough. So just do the best you can. If you can only get them up at like 8 a.m. instead of 7 a.m., that's fine. Like we'll take it. We're also reasonable in CBTI. We use motivational interviewing and work really closely with the client, parent, kiddo to come up with like reasonable expectations for sleep. If a teen is struggling with feeling exhausted during the day but reports he's able to sleep well at night, would naps be recommended? Tamara, that's a really good question. That's something to try for sure. And asking if they snore a lot at night, seeing if their BMI is high, or seeing if anyone's observed them stop breathing during the night, might be good. And if nothing else, and they're still really, really tired, going to see a pediatric sleep specialist would be indicated. Yeah, to figure out what's going on. There might be something happening in their sleep. And no screens before bed, things like that. Yeah, could be that reading can knock you out, Brooke, because you associate reading with bed. Do you have any recommendations for using CBTI as a behavioral intervention in primary care settings? Yes. Um, there are, I've used CBTI in a primary care setting. So Sabrina, please reach out to me and we can chat more about that. This is my email address. And then the contact for our clinic. Like ashwagandha works for some and not for others. Is it possible to get a copy of these slides? I'd be happy to share them in the chat if that's something that's okay, Jessica.
Kristen, we will be posting all of the videos from this series and the slides on multiple websites, and anyone who's here today will receive an email when they're posted.
Amazing. Well, thank you so much. I think that I got to most of the questions. If there's anything that I haven't answered, please reach out. I'd be happy to chat about it. I really appreciate your being here and for helping, care for our kiddos, our community, and yourselves. It's really important. And I'm here to help. So thank you.